that.
Yeah, perfect. Thank you. All right. So aims of today's session. So like I say, just to gain familiarity on sort of the different specialities of patients on ICU and just knowing what the LGI ICU does and what sort of patients that we see on there, to understand common problems that may occur in these patient groups, be aware of any sort of specific cautions or contraindications related to those patient groups, and for a lot of you it will just be refreshing existing knowledge as well. So sorry, you guys need to click on. So these are the main sorts of patients that we will get on general ICU. So again, for those of you who don't know, general ICU is L6 or L7. Due to COVID, it was predominantly on L6 was general ICU, but now it's currently on L7. At some point it might move back to L6, but they're sticking to L7 for now. But pretty much if you get called in, you'll find out that one of the units is empty and one of them's not empty. So I'm sure you'll find where your patient is. And it's just off the main corridor on C floor. So different patient groups, we get a lot of trauma patients coming through. So obviously Leeds is a major trauma centre. Generally patients who've had major trauma are pretty critically unwell. So they come basically from theatres to us. The sort of standard elective surgeries that we do get on there are vascular and then your ENT max fax ones, but obviously you'll get some traumatic ones, so from your major traumas, from any traumatic vascular stuff, but generally sort of laparotomy, any urology, abdominal, liver, lung, etc. is all done at Jimmy's, so we don't get any of them. And then obviously cardiac surgery, you just heard, has its own ICU, so we sort of get the other specialities that sit about in here. Cardiology make up a good proportion of our caseload, quite often with out of hospital arrests, but sometimes we'll get some of the poorly patients off cardiology, and yeah, sometimes some of the ones that have sort of had the percutaneous coronary interventions or the TAVIs, they might come to us post-op just because there might be that little bit higher risk. And then obviously we get neurological conditions, so your GBSs, transverse myelitis, myasthenia gravis, crises. You'll have heard, hopefully Lindsay or whoever was talking about neurosurgery, you'll have heard her talking about spinal cord injuries, but sometimes they will come to us, especially if it's more of a non-traumatic spinal cord injury, maybe like your spinal infarct or something like that, where it's not actually a traumatic C-spine injury or whatever. And then I didn't quite get a chance to finish my slide on COVID, but we obviously have had COVID patients, but touch wood, we've not got any COVID patients at the minute and hopefully won't be having any anytime soon. But I will cover just a little bit about COVID and what to expect from it. Okay, so those are sort of your patient groups. Obviously we then just get any outliers from any of the wards on in the LGI. So sometimes we'll get an orthopedic patient, sometimes we'll get a stroke patient, and different people can bob up and bob onto ICU, but these are our general caseload. All right, so we'll just sort of work our way through the different presentations. So major trauma, as I said, you could have someone who's literally just come post-op for monitoring, or it could be someone who has every bone in the body is broken and they've had multiple surgeries. So some people will be intubated and ventilated, some people will be just on room air and might just need a bit of blood pressure support. So there's a massive array of the presentations of your major trauma patients, and so long as they don't have a significant head injury that's sort of needing neurosurgical intervention, then they will come to us. But if they need any neurosurgical intervention, have an ICP bolt, anything like that, then they'll be on neurosurgery. But if they don't need any neurosurgery intervention, then they'll come to us. So you might have heard about the one click. I don't know how many teams out there are doing it, but we generally, as a day team, we'll generally do a one click for every patient coming onto ICU. And it's especially important for sort of your major trauma patients, because all of your injuries should be listed on that. And also all of the management plans for those injuries. So if they've had the tibia fix and they've got an X fix on, and they're not allowed to wait there for 6 weeks, that should be documented, and that should keep being sort of updated as plans are made and things change. So hopefully, if you do get called into one of these patients and you're a bit unsure, can I sit them? Can I do this? Can I do that? Hopefully, it should be documented what they are allowed to do, or sort of any questions or queries about what you can do with them should sort of be covered in the one click. And obviously, if there is, for whatever reason, if you got into a major trauma patient and you thought the best thing for me to do is to sit this patient, but I'm not sure about a specific injury, then it would just be trying to contact their home teams, or trying to contact MTC, or if it's a plastic surgery, a graft or a flap or something that you're not sure about, trying to contact who's the on-call reg for who's in charge of that at the time. So, but hopefully anything should be sort of cleared up, and if we should be documented if they're not allowed to sit, or if there's something stopping us from doing something. Yeah, so I hope that's what we'd be looking at from the major trauma point of view. Obviously, I think from a respiratory point of view, the main reason why these patients will go off is from pain, or especially if they've got any thoracic injuries, so any rib fractures, lung contusions, sternal fractures, clavicle fractures, anything thoracic will stop them from ventilating effectively and potentially coughing and clearing effectively. So they then might, come into some respiratory complications. So your analgesia is always one of the main things that you need to think about with these patients, to make sure are they appropriately pain managed, or are they over pain managed in some circumstances where people might be fully knocked off because they've had a ton of morphine in the day and they can't even cough to command because they're so knocked off. So that's sort of some of the considerations. So like I say, if you are called into one of these patients, quite often the main reasons why will be because of being in pain, or they've got an altered GCS, or both, that are sort of driving each other. So again, questions to ask on the phone: is the pain well controlled? Are they coughing? Are they clearing? If not, why aren't they doing it? Is it because, what's the GCS? Is it because they're not following commands? And then when you get in to treat them, you've got to make a consideration of all their injuries. So like I say, hopefully that one click should be filled in. Do they have rib injuries? Do they have rib fractures? Do they have any flail segments? And obviously they may be in a collar or something like that. And if you're going to reposition them, you just want to check with the nursing staff what can you actually do from a repositioning point of view. But like I say, I think the main reason why these patients deteriorate is sort of your thoracic injuries. So as a whole, there's cautions to be taken when people have any rib fractures, especially if it's sort of extensive rib fractures, especially if they've got some flail segments, because you're obviously then at risk of things like pneumothoraces and things like that. If it's a patient that you've been called into and they've got these rib fractures or flail segments and they've significantly sort of fallen off of a cliff, then one of the things that you should be sort of considering, have they had a pneumothorax, have they done a roll, and then they've punctured the lung. So just sort of taking that into mind. So yeah, like I say, it said at the bottom here, be cautious when using manual techniques, positive pressure. There is always that risk of causing trauma to the lung. If someone's got rib fractures, they're going to have lung contusions, so there's always going to be a risk of causing more trauma. But actually, if you go to a patient and their main issue is lungs full of secretions, or they've got a clear whiteout, which is definitely CLAPS and not a pneumothoraces or hemothoraces, then actually you might need to use positive pressure, and that might be the only way for them to recover. So it's just about sort of weighing up what's the risk and what's the benefits. And again, if you're in an on-call situation and you're unsure, there always should be a doctor there that you should be able to get in touch with and say, I'm not entirely sure. I feel like this is their main problem, but I'm a bit worried about treating them because of the rib fracture, the flail segments, and I'm worried about the lungs. And the doctor will probably say, oh no, the main problem that they have is secretions, so do what you need to do to sort of help that. But yeah, it's always just sort of, if there's no evidence of secretions or collapse or anything like that, then you don't want to start jumping on their broken ribs, because it's going to hurt and not be very pleasant and not be very indicated. So just sort of weighing up things. And I think that's sort of all I need to say about major trauma for now. But if anyone has any questions, either fire away now or we'll tackle them at the end. Okay, so I'm just going to go through a bit of the surgeries in general, and just thinking about what might go wrong following surgery. So obviously your trauma patients will come back with multiple surgeries. They might have had metal work put in, they might have had flaps and grafts, they could have had any bone or anything fixed. So generally the major trauma patients have a long time in surgery, so quite often they'll be tubed for surgery and come back tubed and need a bit of time to come around from that. But if we're just thinking of general surgical risk factors, this is just and thinking about, this is probably not for thinking about on call, it's just for that bit of a process. If you happen to be on a unit and you're thinking about screening a patient and whether you need to see them or not, then this is sort of what we'll follow to figure out, oh no, they'll be all right without physio input, or oh no, we should pick them up and sort of see them. So age is always one to consider, and obviously current smoking history, any pre-existing pulmonary disease, so COPD, if they've got an increased BMI, or if you know that they've got any preoperative mobility neurological issues, then we'd obviously be wanting to look at them from a mobility point of view. But yeah, anyone that comes back from surgery and they've got higher oxygen requirements than sort of just normal face mask or nasal cannula, if you know that pain's an issue and they're barely rolling in bed because they're in so much pain, then we probably need to get involved and make sure that they're able to do deep breathing and things like that. Always good to look at the chest x-ray and make sure that there's no changes on the chest x-ray, or if they've got any obvious increased work of breathing, secretion retention, or yeah, if there's a known thing that's going to change their mobility or neurological presentation but from baseline. So that's just risk factors, and it's not necessarily overly relevant to an on-call situation, but it's good to know in the day this is what our team should be doing, and should be sort of, you might come in and think, why have they not picked up this patient? But it might be because we've screened them and they've not necessarily shown for any of these risk factors, so haven't necessarily been indicated to see. And if not, and we're wrong, then let us know. All right, so one of the main things that we'll see is vascular surgery. So quite often, a lot of vascular surgeries just have the theatre, have the surgery, recover in theatre, and then get sent up to the ward. But quite a few will come to us if they need some blood pressure management, or the other side of that, sometimes we'll have vascular surgery patients that, for example, we had a man the other day who was admitted with gangrene, well, not the other day, a couple of weeks ago, admitted with gangrene to both of his feet, and he needed a bilateral below knee amputation because of that. So if they're acutely unwell, then they'll be admitted because of that. Oh, remind me at the end, I had a good major trauma case study that I meant to say when I was doing that, so remind me at the end. So yeah, so they might have been admitted acutely unwell. So your common sort of vascular operations, they might be post AAA repair, so either an open repair, EVAR or TVAR, but I think a lot of them do go to the ward. Above knee, below knee amputation, again, some of them will just go straight to the ward, but the ones that are needing a bit more support will come to us. Any bypass grafts, and then type B dissections often aren't surgery, but they are a type B dissection. You hopefully just learned about type A dissections. So the type B is any dissection of the aorta on the sort of descending aorta. So they will generally come onto general ICU, where they'll be managed by keeping them, making sure they're not hypertensive. So they use drugs like nicardipine and labetalol and infusions to keep their blood pressure at a certain target blood pressure, and they do it for a few days, and then once they don't need the infusions anymore, but they're still meeting their systolic target or the MAP target, then they'll be able to step down to the ward. But whilst they're sort of being controlled, whilst our hypertension is being controlled from a infusion point of view, then we generally don't, we don't mobilize them, because obviously that could just affect their blood pressure and cause them to become more hypertensive. So the vascular surgeons like them on bed rest whilst they're controlling their blood pressure and making sure they're not getting hypertensive. So the vascular are generally quite good at documenting mobility restrictions. So if you do go into a patient and think, oh, this patient could do with a sit, then you probably should be able to find that information out just from the notes. And generally there's not any sort of unique cautions or contraindications to consider. I suppose the only one is with your type B dissections, if they are controlling the blood pressure and the making sure that they're not hypertensive. If you wanted to sit them, then it'd probably just be a discussion with the vascular surgeons to say they're going off from a chest point of view. I think that the best thing for them is to get them sat, and I don't know, they might be like, yeah, go for it. But it's just about having that discussion. Just thinking of so there was a type B dissection recently who was sat on neurosurgery. He was a young guy, I think he was in his 30s, roofer, so normally fit and well, but I think had ignored doctor's advice and was running hypertensive in the community and wasn't taking any medication for it. But he came on to neurosurgery and they rang over to our team for a bit of advice, because he then started going off from a chest point of view. I think he quite rapidly went on to quite high amounts of oxygen, so they rang over to sort of discuss with our team whether you could use positive pressure, whether there's any contraindications to using positive pressure to sort of help treat him if he needed it. And we sort of reasoned it, and there's no reason why you shouldn't be able to use positive pressure with them patients, because if anything, your positive pressure is going to drop your blood pressure, and that's what they want. They want the blood pressure to be low rather than high. So that was just, and yeah, he ended up tubed and everything anyway, so he was obviously then being delivered positive pressure, tubed and then trached, so he's been delivered positive pressure all through his ICU stay, and he seemed all right at the end of it. Okay, so that's some of the vascular surgeries. Your ENT max vac surgery, so obviously they're sort of completed for your face and neck cancers, and people will have dissections and things taken out, laryngectomies. So they normally come back post-op ventilated to the unit, and they sort of they're quite quickly taken off the ventilator, probably the morning after they've arrived, and then quite quickly moved to high flow, to low flow, and then onto the ENT ward, L23. They do have, if they do have trachees or stomas, they'll go upstairs with a trachea. That they do have humidified oxygen up on 23, so they'll go on sort of heated, humidified. I think they've got maybe Fisher Paykel's. I might be wrong, correct me if I'm wrong. But so like I say, surgeries include a mixture of sort of your neck dissections, where they'll be removing lymph nodes and potentially the surrounding tissues, laryngectomies. So it might be a partial or a total removal of the larynx, and always something that's good to know about your laryngectomy patients is that they will no longer breathe through their mouth and their nose. You need to, depending on if the partial or total, they'll either be a total neck breather or a partial neck breather. But either way, if they need ventilation, it has to go via their neck, and if they've got a trachea, via the trachea. There's no point in trying to bag and mask over the face. And they often do sort of your free flap reconstructions using grafts from fibula, the forearm, or pec major. So again, sometimes they do have sort of weird and wonderful sort of plastic surgery operations done, and they've taken things from different places. So sometimes it is good to read through that op note and make sure that the sort of mobility restrictions, that you're making sure that there's nothing specific on there. But again, hopefully that should all be documented in your one click, depending on when they've come in. But yeah, I think with sort of your ENT and your vascular, your elective surgeries, we don't often have problems with them going off from a chest point of view. They sort of follow a pathway where we will screen them and we will make sure that they're doing what they need to do to make sure that they don't have respiratory complications. Obviously, with any surgery, there's going to be pain involved. So if people are struggling with pain and can't cough and clear due to pain, then that's something that's always to be considered. But your ENT patients, the consultants are always really pretty keen for us to do early mobilisation with them, and we'll try and get them up and out of a chair day one, and they go up to the ward pretty quickly after that. So often, I wouldn't say you'd be called out to your vascular or your ENTs very often. Okay, so moving on. So your cardiology patients, or our main caseload of cardiology patients, your out of hospital arrests. So yeah, most cardiology patients are out of hospital arrest. However, we might have people admitted needing support from pulmonary edema, sometimes following sort of one of the cardiology interventions, your PCI, TAVI. But generally, if they've had complications following that, I don't think many people are sort of booked into ICU post those interventions, because obviously it's meant to be for people who are a bit higher risk anyway. So if they're too high risk, then they won't be going for them procedures. But anyway, that's, yeah, so we don't see many of them. Our main caseload is out of hospital arrest. I think we've got 2 or 3 up there at the minute. We've definitely got 2, maybe 3. So when someone comes in with an out of hospital arrest, I'll just take you through the bit of a pathway that they follow. And again, I suppose it doesn't matter too much for your on-call knowledge, but it's interesting to know. So they'll go straight to the cardiology cath labs on arrival, where they'll have an angiogram completed to identify the cause of the arrest, see if there's any of the coronaries are blocked up. If they can, they'll then put in your percutaneous coronary, do a percutaneous coronary intervention, so put a balloon up and then put a stent in if there's anything treatable. Then they'll come onto ICU, where they'll often have a good bit of obviously cardiovascular support, lots of infusions of different sorts, and I'd imagine Natalie's just talked through the different inotropes and vasopressors, etc. But yeah, sometimes they might go on to generals with a intra-aortic balloon pump as well. So hopefully you already know the contraindications to that as well. But yeah, just don't sit. You can't sit them up. You can't really move them. Got to do what you do in the bed. So yeah, they'll have targeted temperature management. So they'll run the patients hypothermic, and that's to avoid sort of your reperfusion injury. Yeah, which is again to protect your brain, to protect your organs. I can't go into it too much because I don't fully understand it, but yeah, it's essentially just when you've had a cardiac arrest, your body obviously cools right down. So if it then comes up to normal temperature too quickly, then it can then upset your cells and cause damage in that sense. So they use for most patients, they'll use an Arctic Sun, which is essentially it has a rectal probe, and it runs the temperature that you want it to from the rectal probe, because that's obviously the most accurate body temperature, and it's pads that sit all over the body. So the only difficulty for us when someone's got an Arctic Sun in situ is you can't listen to the bases of the lungs, because the pads sit right over the bases, and it's quite a thick gel pad. So even if you try and listen through it, you can't hear anything. So if you've been called out to one of your cardiology patients, then it's about sort of using other forms of your assessment, making sure that you're being quite paying attention to their x-ray and things like that, because actually your auscultation is a little bit hampered. You can probably only hear upper zones, maybe into the mid zones, but generally can't listen onto the lower zones. I'm sure if it was really indicated and you thought, I really need to listen to the bottom of the lungs, then just having a chat with the nursing staff or the doctors, there might be scope to remove it. But I think they're quite expensive of the pads, and it's one patient use, and as soon as you peel it back, then you can't stick it back on. So using your different assessment skills is probably important. So yeah, obviously with your out of hospital arrest, there's always that chance of neurological injury, a hypoxic brain injury from the downtime that they've had. That should all be documented in their one click, and they're on there for respiratory care. So yeah, they'll be on a ventilator. Some out of hospital arrests are on a ventilator just because they want them to stay asleep for 24 hours. Some of them need to be ventilated because they have respiratory complications. Generally, I think a lot of the time when someone has an out of hospital arrest, there's a high risk of vomiting, aspiration. So yeah, 24 hours post the arrest, they aim to wake and wean. So like I say, aspiration is quite common, and that means that they can have increased ventilatory needs. So if we think about a patient following extubation, some of your biggest complications are the fact that they will, the fact that they'll have pain from the CPR. Someone's been jumping on the chest, they might have rib fractures. So again, it's just thinking about, is their analgesia optimized? And also it's thinking about their neurology. So it might be just that they're coming off of sedation and they're not quite as bright and perky as they will be in a day's time, but they might not have a strong cough and they might not be able to follow commands very well, or it might be that they've got a hypoxic brain injury and they do have neurological deficits. So it's really important to pick up on these things to make sure that if they don't have an effective cough and they've definitely got evidence of secretions or they're needing higher oxygenatory support, then thinking about the things that you can do to limit their risk of sort of deterioration. So if they've got that weaker cough, it might be thinking about a cough assist. If they're really flat, thinking about sort of your NP airways. But again, it's always very individual to the patient. I can't necessarily tell you a scenario of what's going on. And I think I'd imagine, again, Nat's mentioned this with regards to the cardiac surgery patients, but you've got to always think about the cardiovascular support that these patients are on. If they're on a lot of cardiac support and you're then going to introduce some sort of high intrathoracic pressures, and that could cause sort of drop in blood pressure and things like that. So it's about weighing up your risk and your benefits. If again you think you've got a patient with lungs full of secretions and actually that might be driving some of their infection and the sepsis and blood pressure requirements, and yeah, just having a chat with the medical team and seeing what they think, and if they can support by increasing your inotropes or anything like that, then yeah, it's just always about weighing up the risks and the benefits. Okay, so I'm not going to go, I don't really need to go over spinal cord injuries very much, I don't imagine, because again, you probably should have done quite a bit with regards to the spinal cord injuries. But like I said earlier, we will sometimes get the spinal cord injuries, and I don't really know, sometimes we will just get the traumatic ones, but sometimes neurosurgery will get them. Ideally, they should really go to neurosurgery because the neurosurgeons and the spinal surgeons look after them a bit better on there. But they do come to us sometimes. So obviously it's just that consideration of what level the spinal cord injury is. And I think we probably get more of the thoracic ones, to be fair, because they're not necessarily, thoracic is treated by the spinal surgery surgeons, rather than, I think the C-spine will be treated by the neurosurgery surgeons. I'm not 100% on that, but I think there is some sort of rules on that. So we'll quite often get the more thoracic spinal cord injuries. But what you've got to think about is cord edema, and it might track up to look like a cervical cord or a high cervical injury. So it's again thinking about the things that you normally would do. If patient has a weak cough, if they've got poor lung expansion, then if they're not tubed, then measuring their FVCs where possible. Quite often, so I'll go on to FVCs in a second, and again, I'm sure you've got a little bit of a knowledge of them from the other PowerPoints, but as far as I'm aware, the general guidance is if your FVCs drop below 1 litre, then you definitely need to introduce prophylactic cough assist at least once a day. I think whether you need it more than once a day is sort of trial and error, and seeing how the patient manages, and sort of reviewing their needs and their secretion load and things like that. But yeah, again, Lindsay probably mentioned about an abdo binder. If it's a new spinal cord injury that you get called into, then it's about getting them an abdo binder if they're going to be sitting up, introducing them to the cough assist and getting them established on the cough assist. Those are sort of the main things that you want to be thinking about. But I won't go into it too much. So yeah, if just for any of you that don't know, your FVCs are your forced vital capacities. Again, this is something that I mean to look into, but for different neurological conditions, there's almost some people use peak cough flow and some people use forced vital capacity. I don't know what the evidence is behind it, and it's always something that I think, I wonder why we don't use peak cough flow for spinal cord injuries when they do for M&D patients. But anyway, that's me going off track a little bit. But your FVC is essentially your total lung capacity, so it should be your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume, and it's about that blowing it out as quickly as possible, your exhalation, and as quickly as possible. I think I looked at mine at what my predicted value should be earlier. I've not tested mine, so I hope it's in the same range, but mine at my age and my height should be 3.67, and then in just over a month's time it should then go down to 3.56. That's my predicted. So if you're thinking about spinal cord injuries, and if we're starting prophylactic cough assist when they're 1 litre or below, then it is significantly less, and that's because you don't have your abdominals, you don't have your intercostal muscles, you might not have your diaphragm. So how are you going to generate the power to be able to then force out air out of your lungs? So it's obviously really important to assist them with that. So moving on, and all of this is obviously your neurological conditions, and again the sort of considerations are all very similar, but the different presentations. So we do quite often get your GBSs, your Guillain-Barré syndrome, transverse myelitises. There's lots of, again, weird and wonderful types of sort of your autoimmune. Are you bleeping? Of your autoimmune sort of diseases. CIDP is one that I can think of off the top of my head, and there's again a sort of a full bracket of these sorts of diseases, but we'll probably generally see GBS, transverse myelitis. We've actually just had a chap who was post-COVID myelitis, so that's an interesting one. In fact, I need to email someone about that, but that's me going off topic. So yeah, in the severest forms, they can result in ICU admission due to respiratory failure. They can easily result in death if not supported properly, and they manifest as demyelinating diseases of peripheral and central nervous systems. And like I said, there's numerous other similar but rare conditions. Often people walk into hospital just with sort of leg tingling, numbness and weakness, and then it progresses distally to proximally and can lead to sort of your respiratory muscle disease, weakness, and then often ventilated and then trached. So yeah, they will generally be treated with IVIGs or plasmapheresis. One of the things, and again, this is something we were talking about recently, one of the things with IVIGs is we won't move or rehab anyone whilst they're on IVIG therapy, due to concerns of sort of increasing their fatigue levels and causing respiratory distress. It's something that, again, I'd like to look into a little bit more and understand the exact sort of process of what's going on there and understand why. But anyway, a bit off topic. So again, with these patients, it's always good to be sort of monitoring your FVCs. Quite often, if they're admitted, they'll go to neurology where they'll have regular FVCs, and if their FVCs are trending downwards, then they'll get admitted to ICU and then quite often electively intubated because they're sort of on that downward trend, and at some point they're not going to have their own innovation to be able to ventilate themselves. So it's better to get them tubed earlier than later, I suppose. But yeah, again, if someone's essentially paraplegic because they've got Guillain-Barré and they don't have any innervation to any of the muscles at all, then you want to be thinking about them in the same way of a spinal cord injury, so like your abdo-binders and your routine cuff assists. So yeah, we literally just had a chat, like I say, with COVID, my myelitis, and he was fine initially, but then we did get him established onto a cuff assist routine, and he got decannulated last week and he's doing pretty well, which is good. But yeah, we did his FVCs after he was decannulated, and I think he was about 1.5. So, and this is a man who is a lot taller than me, so should have his predicted values would be bigger than my lung volumes. So he's obviously nowhere near being able to sort of produce the effort to cough himself, or he's obviously ventilating for himself now, but to be able to effectively cough and clear is still, I think they were planning to continue cough assisting him until he got a little bit stronger. And then again, this is sort of a similar idea. Oh, we're nearly out of time, so I won't say too much about myasthenia gravis, but again, it's your autoimmune disease, and they sort of present like an MS in the community where they will be able to manage in the community, but now and again they might come to a myasthenia gravis crisis, where they have this weakening of the respiratory muscles, and then they might need admitting to ICU and ventilating for a period of time. So again, similar things, FVCs, prophylactic cough assist, don't mobilize if they're on their IVIGs. Okay, this is the last topic that I just wanted to cover a little bit on. So like I say, hopefully this is becoming a thing of the past, but we don't know yet. So I'd imagine if we looked at the stats for call outs to any COVID patients, I think that I don't think the medics have really been calling out physios to COVID, because there's quite a lot about COVID patients on critical care that it's just not physio amenable. They have just rubbish lungs because they have had a disease that has massively attacked their lungs and destroyed their lung tissue and made it become fibrotic and not very fit for purpose. So quite often the patients that we've had on, like routinely seeing on COVID, we would probably be doing things. Well, quite often your COVID patients that are tubed might be prone, they might be paralyzed. Well, if they're prone, they'll be paralyzed. So again, if they do have any evidence of secretions, it has mainly been about your manual techniques, instilling a bucket load of saline and just giving them a good shake, sometimes doing a bit of an assisted cough, and there's other things that can be done on the ventilators which have been seen to sort of help them a little bit, but it's not something that I'd say definitely needs doing. We've sort of done a bit of maybe ventilator hyperinflation at times, but sometimes their peak pressures are already so high that you don't have that option. Sometimes an inspiratory breath hold can just help to increase that expiratory flow and sort of act a little bit like a cough. But I'd say from my experience on COVID, unless they've got past the stage of where the COVID is sort of not the problem anymore, and they've got an added infection on top and they've got massive amounts of secretions on top, then actually, yeah, in the stage where they don't have those secretions and it's just sort of lung damage, and there's not a lot you can do. If they do then move on to a secretion load, then we have cough assisted some of the patients to good effect. We've not really done any manual hyperinflation because in my eyes they have brittle lungs, so at least with a cough assist you can really pinpoint the pressures that you're giving them, so that there's hopefully less chance of causing any further damage or any spontaneous pneumothoraces. Well, it wouldn't be spontaneous, but anything like that. So I think there's just, in summary, there's not a great deal that we can necessarily add unless there's a clear secretion issue, and depending on how far down the line they are. If they're a COVID patient that's recovering, then there's more that we can do. But if they're in that sort of critical stage, then your positioning, your proning is probably seem to be doing the best, and if that's not working, then it means that they're probably going down the wrong path, and they will probably end up having their care withdrawn upon. So yeah, sorry to be gloomy, but that's COVID. All right. So again, this end of the PowerPoint I've not really had a proper look at, apart from adding that COVID bit in. So there's just some on-call tips, which I think Joel wrote up the last time the PowerPoint was looked at. So, and it is good advice, where whenever you're on call, you've just got to really break things down and sort of talk through, think about your multi-system assessment. For example, the type B dissection, the example that I gave earlier of the guy on neurosurgery, he ended up being about 14 litres positive. So obviously, if someone is that positive, and that's because of he needed quite a lot of antihypertensive medication, so they were just giving massive infusions. It wasn't at its highest concentrate, so there was a lot of fluid involved in that. So he just got filled with fluid, which obviously, I think he did have a chest infection as well, but chest infection plus being 14 litres positive really led him to a bit of a respiratory crash. So if someone would have picked up on, oh, we're getting quite positive here, is that contributing to our respiratory demise? And that, well, yeah, once we did pick up on that, then he got a bit better, and his FiO2 started reducing once we started drying him out a little bit. But yeah, just having that sort of logical format will help you identify your problems. So yeah, lung volume, sputum retention, increased work of breathing. And I think the good thing about ICU is that the nurses and the medical team are generally just really helpful. So if you just ask them, they will generally be able to help you, so long as they're in a good mood. So yeah, don't be afraid to ask questions. If you're getting called into someone, asking, have they had a chest x-ray done? Have they had recent ABGs? If they've not, asking, would you be able to do that before I arrive? So I've got something to work on. Yeah. So just before I do any questions, I'm just going to go back because I remembered about the MTC. So there was a really good example that I thought of when I was sort of doing your MTC, and there was a girl who, this was back in last October, and I'd just started on the team, and she had been in a car crash. She had multiple injuries. She ended up having an open abdo, pelvic fixation, femur fixation, but had significant broken ribs. And while she was intubated, she'd had a pneumothorax that had been drained, and yeah, just wasn't in a great way. But she did manage to get extubated, and on the day she was extubated, she was just, her GCS just wasn't cracking. I think she was opening her eyes spontaneously. She was following commands, but just she wasn't really verbalizing. So she just wasn't really communicating or anything like that. And I remember seeing her. It ended up being the last patient of the day. For whatever reason, she'd moved from one ward to another. She'd been for a scan, and I'd seen her at the end of the day, and she did sound like she had a chest full of secretion. She had a really weak cough, and I think that was probably mainly due to her GCS, but also because of pain. And then her analgesia that she was taking, she was a bit knocked off from the analgesia. So it was sort of that difficult sort of balance to get. But I ended up putting an NP area in and being able to suction loads off of her chest with NP suction. And obviously the nurses on ICU were able to do that. So just said, oh, if you don't mind, can you just regularly suction her? Because it did stimulate a cough when I did it, and that was that. But she got called into on that evening, and again, I think whoever came in suctioned, couldn't get anything off of her chest, but then obviously assessed that she had a really poor cough, so I decided that she needed to be cough assisted. So from that point, I think she was cough assisted on that night, and then the next day she was cough assisted twice, and then had BD cough assist for, I think, at least a few weeks, until she sort of began to come round a little bit from a GCS point of view. But she was someone who it wasn't documented that she had any head injury, but obviously she'd been in a high speed road traffic collision. So she, even though it hadn't shown anything on a CT initially, I think she did then go on to develop some sort of slightly altered stuff on her CT head, but that's something I probably just disregarded the fact that she didn't have a reason for a GCS being a bit lower. I just thought, oh, it's more analgesia, things like that. But those are the sorts of patients that might catch you out with just I think she was on nasal cannula when I saw her in the day, but just sounded like she had a lot of secretions, which then cleared pretty easily with MP suction, but it wasn't enough to then stop her from deteriorating further in the night. So often being a bit more proactive and even just saying, oh, she's not coughing very well, let's try the cough assist and see if it's successful. And yeah, I think it was successful, and then it was successful for a few weeks. So that's pretty much general ICU. And like I say, we get a mix of anything and everything, so it's hard to pinpoint exactly what on-call situations you might be called into, but there's hopefully covered a few of the different specialities that you might come across, and there won't be too much of a surprise if you do get called in on there. Does anyone have any questions?